Okay, well, good evening, everyone out there in Cannabis Conversations COVID land. My name is Dr. Timothy Thong. I'm bringing to you live from our UCLA Cannabis Research Initiative studios, where tonight we'll be bringing up our next monthly series on Cannabis Conversations during COVID. It is Halloween, October 2020, and I'm also coming to you live from Los Angeles, home of the 2020 World Series champion Los Angeles Dodgers. So we're very excited about that. Tonight, we have a tremendous show on tap. We have Dr. Margaret Haney from Columbia. But first, before we proceed with tonight's show, I want to highlight a few new updates from our UCLA Cannabis Research Initiative. First, we have a brand new website located here, cannabis.semel.ucla.edu. And please take a look at that website where if you click on the events and videos, you can get all the recordings of our prior cannabis conversations, as well as a number of our symposiums related to cannabis over the last 3 years. We're very excited about that website. We also have a brand new working button on that website under giving. And if anyone is interested in making a donation to the UCLA Cannabis Research Initiative, you see our contact information there to our UCLA Foundation contact. Dr. Cooper will be mentioning more about that later upon closure. Third, we're also so excited to announce that we are now well into the first ever undergraduate course on cannabis at UCLA. Fall 2020, in the Department of Psychiatry and Biobehavioral Sciences is a class, Cannabis and Cannabinoids, from Pharmacology to Public Policy. This is the first undergraduate class to be offered to study and examine cannabis and the science behind cannabis. I wish I was an undergrad again. I can go back and take that course. We'll be offering that class every year. So next fall, should you want to enroll at UCLA, please ask Dr. Cooper, maybe for a scholarship. So with that, we move forward. Also, brand new this month, we now have a Twitter handle. It is at UCLA Cannabis. Now, you can see there, that's a screenshot. Now, we have 56 followers. We don't have the 2 million that we were hoping for, but we will get there. So please, after tonight, please follow us on Twitter at UCLA Cannabis. And there you'll see not only links to our website and to events, but also links to various scientific journal articles and scientific announcements around the world of cannabis. So we're very, very excited about that. And last but not least, we do have next month, please go ahead and put in your calendar, Cannabis Conversations during COVID, our November episode, with the particular focus on cannabis and cancer with Dr. Donald Abrams from UCSF, November 19th, 2020, 5 p.m. Pacific sharp. With that, I now want to turn it back over to introduce tonight's speakers and our conversations. Of course, leading the conversations, Dr. Ziva Cooper, Director of our UCLA Cannabis Research Initiative. Tonight, though, we have the esteemed pleasure of welcoming Dr. Margaret Meg Haney, who's a professor of neurobiology at Columbia. She is the director of the Cannabis Research Lab and the co-director of the Substance Use Research Center. Tonight, she'll be emphasizing some of her research priorities and work in the area not only of medications to treat cannabis use disorder, but also how can we use cannabis in therapeutic ways to increase appetite enhancement as well as manage pains. Thank you, Dr. Meg Haney, from coming all the way in New York where it is late. But with that, I'm going to turn over the rest of the show to Dr. Ziva Cooper and Dr. Meg Haney. Thank you very much.
Great. Dr. Fong, thanks so much for the wonderful introduction. We're so excited to have you join our monthly series called Cannabis Conversations during COVID, highlighting the most pressing questions related to cannabis. Today, we'll be talking with Dr. Meg Haney about her life in cannabis research, where we have a chance to learn about her research trajectory in studying cannabis, both the negative effects and potential medical benefits. Both are especially timely issues during COVID, a time when cannabis dispensaries in many states are deemed essential businesses, and a time when there are increasing rates of issues for which people use medical cannabis, like anxiety, depression, and issues with sleep. It is thought that both recreational and medical cannabis use has increased since the beginning of the COVID pandemic. Today, we will have a chance to learn about the risks associated with use and the evidence supporting the medical utility of the plant. For this conversation, we invite you to click on the tiles in the upper right corner of your screen and turn on the gallery view so that you can see both of us at all times. Also, Feel free to add questions in the Q&A box down below. You may notice that I'm keeping an eye on this box during the conversation. We've already received some really great questions, and we'll try our best to respond to everyone's comments and questions over the course of the hour. So welcome, Dr. Haney. I'm so excited to have this conversation with you about your findings, how cannabis research has changed since you started in the field, and thoughts of how you think things will change over the next decade. It's also a really special honor to have you here, since we actually first met 14 years ago, a day that really changed my own career trajectory, as you have been my mentor over the last decade and a half, and your work has directly shaped my research. So I'm so happy that you're here with us. So Meg, I want to go back in time and talk about when you first started in the field. Your first papers studying cannabis were in the late 1990s and really set the stage for groundbreaking work looking at variables that impacted people's desire to use cannabis. You did this in a laboratory setting using a self-administration model where people had an actual choice to smoke cannabis in the laboratory at Columbia University. And you next demonstrated a couple of years later that daily cannabis use can actually lead to a withdrawal syndrome when people stop using cannabis. Now, this effect had been talked about before, but it had never really been described elsewhere using the procedures that you use in the laboratory. So back then, what motivated you to start this research into the addictive properties of cannabis?
Well, like most things in life, I completely stumbled into it. I had been studying cocaine and opioids up until the point where a very important paper came out in 1995 showing that in animals, you could precipitate withdrawal from THC. So by that, I mean, back then, we didn't really think there was much to cannabis independence and so forth. There were some hints of it, but once this antagonist was developed where, you could actually block the receptors or the proteins where THC, the active component of cannabis, binds, and animals would go into withdrawal states from THC, it really rocked us. Here I was in a lab. We had been doing a little bit of work with cannabis, but again, my focus had really been on cocaine. But my mentor at the time, Marion Fishman and Richard Fulton, the two mentors, said to Sandy Comer, my colleague, and I, we really need to study this. This is an opportunity for us to really understand cannabis dependence and withdrawal. And so she said, who wants to do it? And I said those fateful words, I'll do it. And that changed the course of my life entirely, because at Columbia, we have this incredible resource, which is a residential laboratory, where we can bring non-treatment seeking drug users into the lab to live with us, and we can measure their behavior around the clock. So it's really the ideal setting to carefully characterize the effects of daily cannabis use. So we would bring in heavy cannabis smokers, have them smoke cannabis, at set periods throughout the day. And then I would switch their active cannabis with placebo cannabis, and we could just track everything: their sleep, their mood, their food intake, their cognitive performance, and really get a time-dependent understanding of withdrawal symptoms and when each withdrawal symptom peaked, how long it took to go away. And we could show that it was really a true withdrawal, because if you gave low doses of THC that participants couldn't even tell they were getting, all the withdrawal symptoms went away. So again, it was this opportunity in this laboratory which allowed us to really do a careful characterization of cannabis withdrawal. Now, others in the field have done other studies, outpatient studies and so forth, to similarly show this. And over time, this has now been added to part of the way we diagnose a cannabis use disorder, this withdrawal syndrome. But it's something that still many people aren't aware of, and daily cannabis users are aware of it, but many people in the public aren't aware that this exists. So that just started the whole trajectory back in the late 90s.
So just to go back a little bit, you talked a little bit about this placebo cannabis and this active cannabis. So what is this placebo cannabis, and what was the active cannabis? What was in that active cannabis?
So as some people know, when you want to study cannabis in a federally funded study, study funded by the government, you're allowed one source of cannabis. And there's a farm in Mississippi that provides cannabis for scientific researchers. And so we had that. And again, my mentors had been doing cannabis work. So they had all the licenses in place to get cannabis from the federal government. And so we would get active cannabis, which would have precise amounts of THC in it. And then the placebo cannabis simply had the active delta-9 THC, the primary psychoactive ingredient, had that taken out. It was an alcohol extraction. They took out that active component. So, it was a plant matter. Participants smoked it. It smelled like cannabis. It was cannabis. It just didn't have THC in it. And so, so participants thought, even though they were very heavy smokers, they thought the placebo was weak cannabis. They didn't think it was absent of any THC. So that was important for us because, when we're measuring mood and so forth, we had them smoke this placebo. So in their minds, they were getting something, but in fact, they weren't getting really anything. And so that really helped us maintain the blind to some degree and really, again, capture this withdrawal syndrome.
And how long did people stay in this residential laboratory? Was it like a couple of days? Like how many days did you give them the active cannabis and then introduce that placebo cannabis? Yeah,
it's pretty amazing. We would, in our early studies, we would keep them in, we've done studies 12, 16 days at a time. And it's a pretty unique, not an easy environment. We do a lot of informed consent. So before they move in, we really explain to them what this whole procedure is going to be like. So we have four individual rooms, and we try to bring in 4 people at a time. And again, their day is quite structured, but they would stay for a considerable period of time. So in our early studies, we would have them smoke cannabis repeatedly throughout the day, and then just switch it up, switch the active with placebo. And so there are consequences of living in such an artificial environment. Obviously, that alone is going to affect mood, but you can control for that. You know the effects of time, and you know the effects of living there. But when you can isolate what is happening when you control for everything and just take out one of the components, which is the THC. So that's.
And so you just have them there, and you're monitoring everything they do. I mean, exactly. What they're eating, what their caloric intake is, how many cigarettes they're smoking, if they're cigarette smokers, even how they're sleeping at night, right?
So we're as you know, they would scan with a barcode scanner everything they ate throughout the day, and so we got very detailed information on not just total caloric intake, but percentage fat, the macronutrient intake as well. So we could really break it down and know how frequently they were eating throughout the day. So we know cannabis has a profound impact on food intake, but we could see that it was really increasing the number of meals people had rather than the amount they were consuming in one meal. So you could really get a very fine-tuned understanding because they were there. They were in our lab, and we were just measuring absolutely everything. We have cameras throughout the lab. We're not recording anything, but we're not taping it, but we're recording all their behavior as it's happening. And then the sleep, they're wearing a device that allows us to capture, how well they're sleeping, because that's, food intake, sleep, mood are the key behaviors that cannabis is really affecting. So this lab is just really invaluable, and it's pretty rare. There used to be more of them throughout the country, and there's very few now. So I feel privileged because we can ask a lot of questions in that laboratory environment that is much harder to ask when you don't have that level of control.
Right. So we're getting a question here about how you define the withdrawal symptoms. So what were the most profound changes that you guys observed when people started using the placebo cannabis after having been on that active cannabis for so many days?
I think the most robust symptom is really sleep disruption. That's a very clear one. That and the market effect, and the one that kicks in first is the decreased food intake. So that's the first thing that shows up when people are abstinent or abruptly made abstinent from active cannabis, is their food intake plummets. It goes down from maybe 2,500 calories a day to 1,000 calories a day. It really plummets, and it plummets very quickly. It recovers in a few days, but those first 2 days without cannabis, there's a real effect on food intake. Sleep is disrupted pretty quickly too, and that stays disrupted. One of the in fact, my colleague in the field, Alan Budney, has shown, one withdrawal symptom is increased dreaming and nightmares when people are made abruptly abstinent. And that effect seems to last for a very, very long time. And it's, cannabis can blunt the REM stage of sleep. So when you take that out, dreaming is just increased. So that's a really common one too. But then the mood symptoms. So these studies are really hard to do because these participants are not easy to live with. So they're irritable, they're anxious, they're restless, and despite, we do, as I say, we do a lot of informed consent, letting them know that their cannabis is going to change from day to day, and they might get uncomfortable, and they do, and they're hard to live with. They're hard to live with for that period of time. So, these studies, withdrawal studies, in any species are hard to do, and it's true for cannabis as well.
So just out of curiosity, when you guys started studying this effect back in the 1990s, what was the strength of cannabis you used for these types of studies?
So it was low, but so was cannabis on the street back then. So I think in our early studies, it was about 3%. We tested a couple different strengths of it. Some of our early studies were as low as 1.98%. And so, of course, that's a topic that's raised all the time because throughout my career of studying cannabis, because the farm we get the cannabis from, the NIDA farm, can't keep up with, the street concentrations of cannabis. But in my opinion, it's not a fatal flaw, because what I do, the cannabis I'm testing now is about 7%. In our laboratory. And again, these are in heavy daily, wake and bake, smoke all day smokers, but they're fine in the lab because I just have them smoke a lot of it. So it might be less potent, but if you smoke enough of it, they're fine. They're getting exactly to where they want to go. So, people say that the validity of the NIDA marijuana is not so good, but my argument is, again, if you get enough in there, they're getting the effect. And I would know if these guys were uncomfortable, I would know.
And so you don't start seeing withdrawal until the placebo cannabis is introduced. And about how long does it take for it to usually peak?
So the anorexia or the decreased food intake happens quickly. Sleep is the next, I would say, but the mood symptoms really start to peak around day 3, 4, 5. They take a little bit longer. And, it's largely, unlike tobacco cigarettes, where withdrawal symptoms kick in very, very quickly. If you're a regular smoker and you go a couple hours without a cigarette, you're going to be uncomfortable. But THC, the active ingredient to marijuana, has this long half-life. It just slowly seeps out of the body. And it's for that reason that the withdrawal does take longer to kick in, unlike something like tobacco cigarettes.
And so when you screen participants for your studies, you probably ask them, do you experience withdrawal when you stop using cannabis? And do people frequently say that they do? Or I imagine, since it takes so long for the withdrawal symptoms to start, if you're a daily cannabis smoker, you're probably not going to encounter those withdrawal symptoms.
Yeah, that's been a very interesting evolution I've seen over the years. When I first started doing this research, the cannabis smokers were pretty defensive of their cannabis and the cannabis use, and they would universally deny that they experienced any withdrawal symptoms. And in fact, when I would do these inpatient studies, the participants would very clearly be in withdrawal, but they would leave because the pillow was uncomfortable, or they didn't like the food, or they would come up with other reasons for why they were leaving. But over time, I feel like in the daily cannabis smoking community, it's much better known that this happens. So now I do get most people saying they understand, even though they smoke every day, they've had periods for whatever reason where they couldn't, and they know that they get they get pretty irritable, and that their, spouse or partner doesn't like being around them, and so forth. So now there seems to be a greater awareness that this is happening, and so they admit to these things, and they're reporting the same things that we see. So sleep, mood, because again, many of them are using cannabis to relax and to take the stress away. So that comes back and bites you when you're not having it. You're feeling those symptoms even more than ever. So that anxiety and restlessness.
Right, absolutely. So how did these early findings shape your research going forward?
Cannabis, more than any other drug I've ever studied, is just so much fun because there's just a million questions to ask about it, again, from either the therapeutic potential, but also the abuse related effects, because it's an old drug, but it's really been very poorly studied, for a lot of reasons. When I first started doing this research, nobody cared about cannabis at all. Scientists were bored by it. Nobody was interested. I would give presentations and I would just get like silence. It was not a topic anyone had any interest in, scientists included. Thankfully, that changed. I stuck with it, and that changed completely. But in the beginning, it was just thought of as just a boring thing to study. They called it like a harmless giggle. There's nothing there to study. But that of course has changed.
Wow. So I can't even imagine, now when you give presentations about cannabis, I mean, you have packed rooms and people have so many questions. It's hard to imagine, I guess before this withdrawal syndrome was documented, people probably didn't really think that there were negative effects. And I think a question that we're also getting is about the high potency products that are available now on the market. So you are studying 7% THC cannabis, and the dispensary in Westwood. When you go into the dispensary, typically they have cannabis that has up to 30% THC, and then there are all these products that are considered really high potency. Right. So dabs, wax, shatter, they're extracts that are almost 100% THC. Right. And one question that I get frequently is, do we know the effects of these products? Or, should people be concerned about using those products? What can we take from what you found in your lab and apply it to what we know about these high potency products? And can we study those high potency products?
I haven't found a good way to study those high potency products. So that gets back to just the complications of trying to study cannabis and cannabis products in a careful scientific way. So, there certainly are researchers that have found very creative ways. Cinnamon Bidwell and Kent Hutchinson in Colorado have found ways to track people. They have people smoke in their homes, and then they conduct a series of tests, blood work and cognitive tests and mood tests and so forth. And these data are still coming out, but I think one of the things that is noteworthy is that they're getting plasma THC levels with these very, very high potency extracts that are incredibly high, like a way that is very, very hard to see, with 7% THC. Yet the disruption in cognition is pretty minimal. So that's telling us that there's tolerance that develops pretty rapidly or pretty consistently that suggests that there's real tolerance. So what are the consequences if you're getting THC plasma levels that high? My guess is going to be people are going to just be using it more and more and more and more. So it's a bit concerning. I would not want people to develop. I don't know what that kind of use disorder looks like if somebody is using at that level. These are questions we don't have the answers to yet. Originally the one thing you and I know from some of our earlier work is that cannabis, when you're smoking the plant, people smoke enough to get to where they want to go. So if it's strong, they smoke less. And if it's weak, they smoke more because they want to get to a certain level. You can't really do that when you're smoking dabs or shatter or 90%. You can't control it in the same way that you can if it's less potent. So that's the other thing. It's concerning to me. I don't know where it's all going to end up. And I don't know what a withdrawal syndrome would look like. And I don't know if I want to be the one studying that.
So actually, before we get into your studies looking at the therapeutic effects of cannabis, which I want to get to in a minute, we are getting some questions asking if you can compare the cannabis withdrawal syndrome to other types of withdrawal from other substances. So a lot of us have experience with caffeine. Right. Is it, and I can time, if I don't get my cup of coffee at 8 o'clock in the morning, I know what I'm going to be feeling like at 8:15 in the morning. Is it like caffeine? Is it like opioid withdrawal, heroin withdrawal, cocaine withdrawal? Right. How do we think about this with respect to like the public health impact?
Yeah. So I think, and again, Alan Budney and Ryan Vandry have kind of done comparison studies. I think a good comparison would be tobacco withdrawal. The symptoms aren't identical, but the magnitude of the symptoms are comparable. So we know that for tobacco cigarette smokers, that's playing a role in maintaining their habit. That discomfort, that craving, the irritability is driving that use. So to me, I think that those symptoms, those mood symptoms of withdrawal are actually essential. Opioid withdrawal is, of course, extremely dramatic, but opioid users will tell you what is the most distressing to them is the mood, the anxiety, the extreme discomfort in their mental state, the psychological state. That's the worst part of their withdrawal. It's not diarrhea and the other things, the flu-like symptoms. So these mood components are really important in maintaining the behavior, I think. Irritability, anxiety, restlessness, those are uncomfortable states to be in. So I think in terms of the magnitude or severity of the symptoms, probably tobacco withdrawal would be the most comparable. It's certainly not life-threatening like alcohol withdrawal or, we did study cocaine withdrawal in the laboratory, and I got to tell you, I'm more impressed by marijuana withdrawal any day of the week. We could never really document cocaine withdrawal very well.
So interesting. So I know that you've dedicated a lot of time in your research looking at therapeutics that can actually help with cannabis withdrawal, because it seems like one of the reasons why people continue to use cannabis, even if they want to cut back or actually stop, is this withdrawal. So what types of medications have you been looking at that might be helpful for withdrawal and to actually help to curb use of cannabis in people that would like to stop using?
Right. So we've tested, I think that last count, 15 different medications for withdrawal, and or maybe about 12 for withdrawal and 3 for trying to attenuate the cannabis high. And not surprising to anybody in the substance use field, but the ones that work the best at curbing withdrawal are THC or like compounds. So there's FDA approved THC pills that have a very slow onset and a long duration of action, and they never get you that same kind of powerful high and good drug effect that smoking does, because it's that oral route of administration. And if you give low doses kind of throughout the day, withdrawal symptoms are really taken care of. Now, we're not thinking, I never think of this like a methadone approach where you would do this for forever. It would be more, ideally, you would help somebody break that habit of smoking throughout the day. You get them through the discomfort, again, like a nicotine patch or a nicotine gum. You get them through the discomfort, and then they wean off that as well. So that's the other thing that I think a lot of people are surprised by, is how many people can't stop smoking cannabis. So again, it's the cannabis use disorder does not disrupt lives in the same way that cocaine use disorder or alcohol use disorder does, but it's still distressing to the people who are smoking every day. They try to quit and they can't. So we want to have something available, like we do for other drugs, to help with that, because they fail at quitting on their own for the vast majority, and they fail even when they get behavioral treatments that work. The vast majority are unable to quit.
And so right now there's actually no medication to help with this.
Correct. There's nothing FDA approved, and there's nothing that's really been demonstrated in the, so, in our lab, what we're doing is testing a range of medications, looking for something that has a good signal to justify doing a larger clinical study. So in patients trying to quit their cannabis. And so we're not looking at that population. We're looking for a signal, a medication that looks promising. And then we move it down the road and hope that our colleagues who do clinical work will test it. And to date, nothing has worked. There is one study by Kevin Gray in adolescents that show a medication called N-acetylcysteine. It has worked. That I think more is happening there. But to date, there hasn't been anything that has worked really well.
So I just got a question about CBD. So CBD, cannabidiol, is a component of the cannabis plant, and it's not psychoactive. It's not intoxicating. It's psychoactive, but it's not intoxicating. And we'd have to be living under a rock to not see CBD on billboards and your Bed Bath & Beyond circulars. And so we got this question: is it possible that CBD might help with cannabis use disorder? Because it does seem like there's an idea that it can decrease some of the negative effects of the THC, the intoxicating component of the cannabis plant.
Right. So there is some indication that that's the case, and there has been a recent study that showed a very small effect of CBD on cannabis use among treatment seekers. We wanted to ask that question directly because it became kind of the lore, and everyone just believed the story that CBD decreased the cannabis high. And so, like most of my studies, I'm driven by irritation, people believing something in lieu of data. So with NIDA, we did a multi-site trial where we gave a range of doses of CBD and then had people smoke active marijuana, cannabis and placebo cannabis to see, could CBD do anything? Did it do anything to attenuate the high? And in our hands, it did absolutely nothing. It didn't change how high people got at all. So that's not the nail in the coffin. Maybe you have to be maintained on it, and maybe we gave up to 800 milligrams, so it wasn't a low dose, but it didn't. In my estimation, at this moment, nothing really convinces me that CBD will be an answer for cannabis use disorder. But it remains to be seen. I just don't see a lot of signals there yet.
So interesting. Okay, so now I want to shift to where you were at in the early 2000s. So in the early 2000s, it seemed like your focus shifted, and you started studying the therapeutic effects of cannabis, which is very different than what you had been doing in the lab before. What was your first interest in this area?
So again, irritability, the lack of evidence, and a lot of people believing a particular story. So I never stopped doing the cannabis use disorder research. That always went on. But in the mid 2000s, right when medical marijuana was taking off throughout the country, and again, we have had this FDA approved capsule, dronabinol, which is oral THC, and proponents of medical marijuana were saying it's garbage. No, it's no good. Dronabinol's no good. It's useless. So. So dronabinol again. So dronabinol is THC. The pill form, it's just a pill form of synthetic delta-9 THC, just put in a pill form, as opposed to the cannabis plant, which has primarily delta-9 THC, but of course many other components to that plant too. But there was just accepted that dronabinol was garbage. It doesn't help for therapeutic indications like HIV and appetite and just GI discomfort and that sort of thing. So we were funded to do a study where we could really directly compare different strengths of cannabis to different doses of dronabinol, and lots of placebo mixed in there too, in people living in our lab who had HIV, were maintained on medication, had a lot of GI problems, difficulty with food. So, they were not acutely ill by any stretch. They were healthy, but they were on medication and they had a lot of discomfort. So every day they would take pills 4 times a day. They'd smoke cannabis 4 times a day, but only one would be active at a time. And this allowed us to really tease apart the placebo effect, what was just the expectation that something was going to happen, the effects of the dronabinol, the oral THC, and the cannabis. And the answer to this very hard and long study was that both worked very well. Dronabinol worked well, cannabis worked well in terms of really increasing food intake, decreasing stomach distress, over-the-counter use of stomach medication. Only cannabis got them good and higher. It had a more of a positive abuse-related effect than dronabinol. Dronabinol did have some intoxicating effects, but cannabis always gives you a better intoxicating effect than the oral medications. And so that was our answer. Both do work. Dronabinol works, cannabis works. They both help.
So interesting. So at this point, I guess it sounds like one question that people might have for you is, you're still studying the adverse effects of cannabis, but you're also very much interested in the therapeutic effects. And in fact, you have some studies ongoing looking at the therapeutic effects. Do you really integrate looking at both of these in one study, or do you keep them separate? Do you recruit different populations of people, or how do you manage to keep the research going in these two seemingly, very different ends of the spectrum with respect to cannabis and its health effects?
And so that's what I feel very strongly about, because cannabis is such a polarizing drug, and it's polarizing in our society, and it's polarizing even among scientists often. So it's all good or it's all bad. It's going to make children schizophrenic, or it's going to cure absolutely everything that ails you. And that's kind of our public discussion about cannabis and CBD and the components. that I find distressing, because obviously it's a complex plant. It has both abuse-related effects and it has potential therapeutic effects. And so my passion and my religion is studying and teasing apart what it really is doing that's different from what placebo is doing. Because right now, particularly for the therapeutic end, it's all being driven by observational studies. It's being driven by what are people at dispensaries going there for, but that's not giving us really clear empirical evidence about what it's being used for. Because when you believe something's going to help with your pain, we know from many, many, many years, it does help with your pain. If you think CBD lotion on your arm is going to help with that pain, your elbow pain, it literally will decrease that whole pain message. But that's not evidence of it really being an efficacious medication. That's why we have placebo control. So that's a long way for me to say that in all of my studies, I'm always measuring abuse-related effects, no matter the patient population, but also having placebo involved as well. So I can be sure that whatever we're seeing is truly a medication effect.
And so a question that we get sometimes is, as you pointed out, there's a lot of anecdote, there's a lot of personal success stories, right. Really tremendous personal success stories that we've heard about how people have been helped, they've had their lives back because of their cannabis and CBD use. And you mentioned the placebo effect. You mentioned that, some people can have a profound therapeutic placebo effect. Is that not enough in this situation? I mean, do we need to go beyond it, or is it okay? I mean, a lot of studies with different medical health indications have seen, success with placebo. Why do we need to actually do the expensive, rigorous studies to demonstrate the effectiveness of the CBD or the cannabis compared to placebo if we think that the placebo might just be working?
So, I don't want to deny anybody, a positive response to a drug. So for an individual using something that they believe is going to help them for whatever it is, and it does, that's fantastic for that individual. But if as a society, that's how we decide something's an effective medication, marketing is going to be the thing that determines what's a medicine or not. We're just going to depend on marketers selling you a product and saying it's going to work. Unless we do these studies that can demonstrate that it works, I think it's unethical. I think a placebo effect is a profound effect, and that's fantastic for an individual, but we can't leave it for our public policy to be decided by marketers. And that's currently where we're heading for CBD anyway. And CBD is a component of the plant that I actually have a great deal of interest in for particular therapeutic, effects, but it's not going to work for everything that it's purported to work for. And it's not going to work when you're buying it at doses nobody even knows are there. So yes, I'm glad that, again, somebody's aunt can fall asleep more easily when she takes the CBD she buys at Bed Bath & Beyond, but that can't be our public policy.
Do you think that there are risks? People are using CBD and they're getting an effect, whether or not it's because of expectation or because if it's a placebo effect. I mean, are there risks with using CBD or cannabis that we should be mindful of?
Right. Yeah, no, there definitely are. There's several things. First of all, the animal studies show that, at not even that high doses, it can affect liver function. It certainly can affect the metabolism of other medications people are taking. And also, if somebody is ill, immunocompromised or, just got cancer treatment and they're taking an unregulated product, we don't know what is in that. We don't know what we're getting. There's no product of CBD right now that I would recommend to somebody who is ill, even if it's for an indication I think it might have benefit, because I don't trust anything being sold anywhere when nobody's regulating it. We don't know what it has in there. We don't know if it has other active ingredients. It's way too risky. So, if there were a well-regulated product, it would be a different situation. But because of the crazy regulatory land we live in right now, where technically cannabis is still illegal and a Schedule I drug in the United States, which limits everything in how we study it, it's kind of the wild, wild west.
That's a great segue. We're running out of time, but I want to make sure I hit on a couple of things. So you've been doing this for about 25 years, and I'm sure the work has changed over time. And you've touched on this over the course of our conversation, are the barriers to your research. And I'm wondering, what do you now in 2020, where over half the United States has legalized medical cannabis use, for you as a researcher, what are the most significant barriers? Because I think that a lot of people think that there's been a lot of research in this area already, given that it's widely available and accessible. But as a researcher, what are the most frustrating aspects to getting this work done?
It's horribly frustrating. It's really, really frustrating, because what we need are placebo-controlled studies, and let's do them for everything, and let's do them for every ratio and the different cannabinoid, the components of the cannabis plant. There's a million questions for which we might get a good answer. But we need to do the right studies. And because of the fact that the DEA considers this federally to be an illegal drug, we're completely hampered. So we can't do the research we need to do. We really need to do, because people are gobbling this stuff up everywhere, state by state, for everything. And we don't know what what the consequences are. So if somebody has depression and anxiety, that's one of the most common reasons people go to dispensaries for cannabis products. We don't know what the consequences of that really are. There's really not great data that's going to be helpful for anxiety or depression yet. So let's, if it were, legalized or what the DEA allowed at least federal researchers to treat it, not as a Schedule I drug, it could open things up. But right now we are so hampered, and it's really a public health problem because people are taking it regardless of the science, and we need the science.
So do you think that if cannabis was removed from this Schedule I status, and just to remind listeners, Schedule I status means that of a drug means that it is federally illegal. It's on par with LSD and heroin. It is deemed to have abuse liability and no therapeutic utility. So it's really hard you need a special license. And Meg, I don't know if you remember how long it took you to get your Schedule 1 license. We had Don Tashkin on last month, and it took him 2 years to get his Schedule 1 license in the 1970s. Hopefully it's gotten a little bit better. My experience is that it got, I think for me, it was about 15 months. So it's not too much better. But so do you think that if cannabis was just taken off Schedule 1 status, that the research would be, the doors would open and we'd be able to answer all these questions that people have?
So, it would help tremendously because, we also have to keep it locked in a safe that is behind, a billion walls. And so there's so many limits, but I also you can't easily send people home with what you want to do in a clinical trial is send some people home with placebo, some people home with active drug. You can't do that with a Schedule 1 drug. So we really need loosening. And there is some congressional movement to allow scientists to actually treat it like a Schedule 2 or Schedule 3 drug, which would help us tremendously. I forgot what your question was there.
No, so that's it. So Schedule 1 loosening would help. And what about funding? In the past, it seemed like funding related to cannabis from the NIH was really just about the adverse effects, the abuse-related effects, the way that it impacts your memory. Is that still the case? Has funding loosened up a little bit so that you can look at the therapeutic effects of cannabis?
I think so. I think because of the opioid crisis, and there is evidence, as you know well, that it can be helpful for pain. I think that's really opened things up a lot. So, we still want to capture abuse-related effects as well with any effects on pain. But I think that has broadened interest from NIH. Is can it have opioid-sparing effects? Will people who are using cannabis for pain use less opioid? And that would be really good. Just one very quick thing I wanted to mention about the DEA. So of course that would be fabulous if we were able to do a lot of these studies I was describing, but there's another regulatory body, the FDA, that appropriately wants to make sure that when you're when you're doing an experiment and giving people cannabis, they want to make sure that it's good. It doesn't have pesticides or, microbes or anything like that. So that would still be a requirement that we would have to go through. We would have to still demonstrate that any cannabis we're giving to people is not harmful. So that one's not going to go away, and it probably shouldn't. I think that's an important component to research, scientific research.
So I just got a question here about Epidiolex.
Mm-hmm.
So Epidiolex is almost pure CBD, and it's no longer scheduled at all. So you could use it in your studies without a problem. But this is interesting. Unlike other drugs, it cannot be prescribed off-label. So Epidiolex, this nearly pure form of CBD, is approved for some pediatric epilepsy conditions. But physicians cannot prescribe it for anything else. And it might also be very hard to use for research as well. So this question is, do you have any prophecies about this, how this might change in the future? Do you think that the FDA might have pressure from researchers to be able to use Epidiolex for researching other health indications?
The DEA doesn't seem to take pressure from scientists to heart at all.
The FDA or the FDA or the DEA, yeah.
Oh, okay. There is this farm bill that has loosened, that is now allowing hemp, which is, where we can get CBD that is also not scheduled, that I think is going to help open things up as well. I'm not sure about the Epidiolex story. That's a really good question. I had no idea it wasn't allowed to be used off label. That seems unusual and odd, but I'm hoping that with this farm bill that scientists will have access to good CBD, because right now that's not even easy to study scientifically, because there's no good source of it really. Not
That's frustrating.
Yeah.
So frustrating how you can go to Bed Bath & Beyond and buy some for your dog, but you can't use it on your participants. And so, Meg, I have a recollection of about 5 years ago when I was at Columbia, and we had a doozy of a couple of weeks with the FDA and the DEA and participants, and it was a really challenging couple of weeks. I mean, it's all challenging, but those weeks in particular. And I walked down the hallway and I knocked on your door and I opened up your door and I saw you there and you were smiling, light beaming from your face, whereas I was feeling downtrodden. And you said, "I love my job." I don't know if you remember that. In fact, you probably said it to me multiple times. And so I'm wondering, you know, with all of these hurdles and how hard it is to do this research, what keeps you going? What is inspiring to you?
I still love this job very, very much. You know, it's just the questions are endlessly entertaining and fun, and I happen to like working with marijuana smokers very much. No, just that the questions, just you know, designing a study and then getting the results, there's nothing like it, you know. And it's a good thing I love it because I am skilled in nothing else. This is the only job I've ever had. Since I was a fast food worker in high school, this is the only job I've ever had. So thank goodness I love it because I got nothing else.
Do you have any exciting studies on the horizon or ones that you're doing right now that you think are particularly exciting or interesting or inspiring?
So, you know, with Diana Martinez, we are doing a study that I really find very exciting, which is high CBD, low THC capsules for neuropathic pain for women who have undergone chemotherapy for breast cancer and they develop this you know, debilitating neuropathy. And there's studies in mice showing that this combination can be very effective. So we are underway with this. It's just a very exciting study to be doing. And then of course, I still have my my cannabis use disorder crowd coming, and that here I'm really interested in the impact of tobacco smoking in combination with cannabis, and because there's evidence that if you're a tobacco smoker and a cannabis smoker, quitting cannabis is extra hard, and so we really want to tease apart what it is about that makes it so tricky. So we got lots going on, but those two pop to mind first.
And just out of curiosity, the study with breast cancer patients, how long did it take to get that off the ground?
Forever, because again, since I have no source of CBD and THC that the FDA and DEA like, we had to import it from Canada, from a company called Tilray, and they very generously supplied it to us. But getting the DEA importer's license to import a Schedule I drug is no walk in the park. So that was a brutal study to get going, and yes.
So before we close, and we have a lot of other questions to get to, I'm so sorry we can't get to all of them, but do you have any last words for our audience regarding the health effects of cannabis and cannabinoids, any take-home points or health concerns that the audience should keep in mind, or last statements of hope regarding the potential beneficial effects of cannabinoids and the future of research?
So coming from a person who, again, I'm agnostic, or I'm hopeful about cannabis and cannabinoids for certain indications, I just really want buyer beware. Just don't believe everything you read, or just because CBD is slapped on your hair conditioner or is in a candle, don't think that that's going to help you, because it can't even get into your body. So just have a little bit of skepticism, because marketers are going heavy and hard, and there's really a good incentive right now to make, to get people to use cannabis and abuse it, and to buy every product that just has it's slapped on the label. So just have a good, healthy skepticism about it, without disregarding the whole thing, but just be skeptical.
Great. Thank you so much, Dr. Haney. I want to thank you, Dr. Haney, so much for your time, and each and every one of you for joining us today, your insightful questions, and to the SEML staff and audio-visual team for helping with the technology, and the UCLA Cannabis Research Initiative staff for organizing this event. As you know, this programming is free and open to the community, which we do intentionally. The UCLA CRI does rely heavily on philanthropic support to conduct cutting-edge research and educational programs like this today. Our goal is for you to find our webinars educational and insightful, and that they provide important information to the community about the potential therapeutic and adverse effects of cannabis and cannabinoids. In our follow-up email, we will provide a link to the recorded event so you can watch it again and share with friends, and include donation information for your consideration to support the good work we do at the UCLA Cannabis Research Initiative. Your participation in these events and your support are incredibly important and valuable to us, and we sincerely appreciate your time and your generosity. And we look forward to having you join us on November 19th for our next Cannabis Conversations during COVID, where we will be joined by Dr. Donald Abrams of UCSF, who will be discussing cannabis and cancer. Thanks so much. Have a great weekend, and we'll see you soon.